Don Park from Los Angeles. So I'd like to ask the panel, I mean, we heard a lot about anterior, posterior, but what about both combined? With the setting of, say, OPLL multilevel, and you have kyphosis that crosses that K line, and are you able to get that lordosis with an anterior procedure without having to really take down that OPLL all that much, but then use like a posterior-based procedure? And my second question is, I always thought that C5 nerve root palsy was kind of increased incremental compared to laminoplasty versus laminectomy and fusion, posterior based. But it seemed like on one of the talks, it's either or. Like you go anterior, it's low, and posterior is high. But isn't there a gradient where if you do laminoplasty, you have less than, say, laminectomy and fusion because of the drift back and because of the amount that the cord is actually coming back? So if you're combining that laminoplasty and fusion, like you were saying, Jeff, I think that would that solve that kind of question while at the same time addressing that progression risk?
Those are two great questions. I forgot the first one kind of, but the second. But the second one is important because this is why it would be great to have our Japanese colleagues here, because I remember when I did a traveling fellowship to Japan in 1999, they were doing C3 through C7 laminectomies or laminoplasties, decompressions all the time. And then they started moving towards like C3 to 6, saying that they decompressed less, so there's less drift back, less C5 palsy. So I thought a lot of it had to do with the amount of drift back, and you want to control that drift back. But to your first question about the front back, I use that all the time. I think if you have a high T1 slope or you have positive sagittal balance that's regional in the cervical spine, the only way to correct that oftentimes is to go in the front and the back. And what Eeric was talking about, if you try to go in the back, you crank them back, you're going to get foraminal stenosis, and you won't really pick it up because you'll get this myelopathy hand, you'll just attribute it to the myelopathy, and they'll have atrophy. But really, you're probably helping that by compressing the C8 root because you're usually going down to T1 and the C7 root. So if you're going to crank them down, sometimes a lot of people will go just in the front at like C5, 6, C6, 7, open up those foramen, and if you can get to C8, T1, and then crank them down from the back. But if you have positive sagittal balance, I do it all the time. I go front back. And then a lot of times with OPLL, it's a great technique, is to decompress them, or don't get all the decompression from the front. Get this lordosis in the front, and then go after a posterior decompression, and the cord will drift back.
Yeah, there's great question. So in general, I think that for me, I try to avoid going to anterior and LPL as much as I can, unless it's just clearly a situation where it's, the K line's way negative and T1 slope is quite high, so high risk. And even if I take that approach in terms of addressing that, I generally like to start from the back to maximize what I can get from the back, and then do a more limited approach from the front. Figure out where do I have residual central and foraminal stenosis, then do that as a second stage, and then rather than trying to get all the way down to the dura and clean out to get that CSF leak, I'll take more of like that floating technique where I get down and leave and try to decompress more laterally and get that shell disconnected and let it flow away. So most of the time I'd say, look, going anteriorly for me, it's just for OPL, a lot of cases I see long segment OPLL, very densely adherent to the dura. I just don't get the same type of plane that I can dissect as a typical cases. So I only use it in that situation really when it's really kyphotic, but I like to go posterior anterior rather than anterior posterior in those cases.
Do you get like a post-op MRI after the posterior to see?
Yeah. Actually, I do, and I don't know if Jed actually knows. Jeff and I work in the same place, but I actually use the ultrasound a lot now. So so there's, and then it's one of the lost art. I use it for tumor cases for the most part in the beginning, but now I actually, when I get the ultrasound there, with some of the ultrasound, you can really see the core pulsation nicely, and then figure out whether or not you still have residual compression, and then are there any more you can take down posteriorly, and then I get an MRI to verify to decide if I need to go anteriorly or not in a staged fashion.
Yeah, I agree with everything Patrick said, but one point I wanted to make was the neurologic recovery, and it plays into what John was asking before, and even with CSM based on a degenerative basis, Sometimes I didn't see the neurologic recovery I expected, or like you, John, it may get a little bit worse. And if you look, there are any cord changes, any syrinx in the cord, and if I would look at that to see if there's any progression in that, because that can progress on a subacute basis, and that can give you a progression in your neurologic deficit. So, and it kind of plays into when you talk to your patients and kind of determine whether you're going to go from the back, from the front, or from the back and front. I think you need to look at the condition of the cord as well.